We will move on to our next speaker. That's Dr. Baliga, who needs no introduction among the NA Johnite community. He wears many hats, including that of Professor of Internal Medicine and Faculty Cardiologist at Ohio State University. He also has an MBA from University of Michigan and assists in the management of this premier institution. He is from the batch of 1978. He will be educating us on the impact of COVID on the cardiovascular system, including the mechanisms behind the clot burden triggered by COVID. Dr. Baliga.
Thank you, Sunil. I want to start off by thanking Dr. Sunil Babu for inviting me to do this, and for relentlessly also doing fundraising for our alma mater. Next slide, please. Next slide. Thank you. So this is a really important slide. Not the one previous to this. Yeah. So this slide on the left panel shows what happens to asymptomatic individuals. The hypothesis is they have a low viral load, and there's an early interferon response, and there's rapid viral clearance, and there's mild disease. What we have on the left side is individuals with higher viral load, and what happens is that there's a delayed response, and as a result, the response is not in tandem with the viral load, and there's viral persistence and inflammation and severe disease. And this is not only about viral load, it also depends on host factors like the immune status of older individuals, people who are diabetic, people who have hypertension, coronary artery disease, obesity. Essentially, anyone who's kind of immunocompromised has a delayed interferon response, and that's why we see this spectrum of diseases, so as to speak, with COVID. Next slide, please. So this is a busy slide, but it captures all the manifestations in cardiovascular disease. It's a disease of the heart, and it's the disease of the pipes. And the real challenge has been that it's a stress to the cardiovascular system, a stress to the heart, and stress to the vascular system. And in fact, you could argue that delayed immune response, which I discussed in my previous slide, is like a frenemy. You know, the immune response is a friend when it's appropriate, but when it's too late and excessive, that's where we see a lot of the manifestations. So if you start off with the left side of the slide, you can get a septic shock kind of picture with the hypotension, and you can as you go clockwise, then you can get direct viral cardiomyocyte toxicity. So there's myocarditis, and then as you go closer to the 1 o'clock position, you can see there's severe vasculitis, and there's really an inflammation of the vascular system causing clots to form in small vessels and big vessels, and that's why you get a variety of manifestations in the cardiovascular system, and sometimes the whole heart can be affected, and you can get distress cardiomyopathy or Takotsubo. In patients who have vulnerable plaque, you can get the traditional MI, so-called type 1 MI, because the virus ruptures the vulnerable plaque. And so it's interesting that it can affect the cardiovascular system at every avenue, so as to speak. And when the lung is also involved, it affects the heart in the sense you can get cor pulmonale or right-sided heart failure. So you can get the whole spectrum. But the key take home I want you all to take away from this slide is it's really an inflammation of the vascular system. And so what happens is when the inner lining of the vascular system is hyperinflamed, you find multiple clots, and these clots can have downstream effects on whichever organ it's involved. Next slide, please. So while he's changing the slides, one of the key important things is, the way to keep the vascular system stable is to use statins, ACE inhibitors, antihypertensives, exercise, sleep. So that would sort of really keep the inflammatory response in bay and the vascular system stable. This slide is an important slide because as a cardio-oncologist, we use CAR T-cell therapy, and in CAR T-cell therapy, there's cytokine release syndrome, which is very similar to what we see in COVID patients. And very early, one of our colleagues here, a gastroenterologist, she got affected by COVID. And you could see that what we do in cytokine release syndrome is to give tocilizumab, which is an IL-6 receptor antagonist, as soon as they're grade 2 or more. And you don't need to have IL-6 levels. If they have an FiO2 less than 40% and they have a hypotension requiring IV fluids or low-dose pressors, then and probably a troponin elevation, that's when we start considering IL-6 receptor antagonist or tocilizumab. Next slide, please. So it's really so this is what about this the upper part of the slide actually talks about what happens in COVID, which is very similar to CAR T cell and immune checkpoint inhibitor therapy, which we cardio-oncologists have to deal with. It's all about cytokine storm, as you see, and cardiotoxicity. So it's really interesting. I was talking to one of my classmates from St. John's, Lloyd Vincent, who is actually director of the Africa Care Network, and he's based in Dar es Salaam. And he has about 20 patients on hemodialysis, COVID patients on hemodialysis, and he hasn't lost a single one. And he can't afford tocilizumab. So what is he using? He's using colchicine. And so it's really interesting in lower and middle income countries where cost is a big factor. I would consider colchicine if patients are symptomatic, especially if they're getting if they have fever, their blood pressure, they're getting more and more hypoxic. And I'm at the bottom end of the slide, I have one of his WhatsApp message. In his experience, it's a magic potion. So something for you all to consider. Next slide, please. So we talked about clots, and clots is a big deal. A lot of the pathophysiology is thromboembolism downstream. And the real key take from this paper is that the routine prophylaxis we give is not adequate because it's such a hypercoagulable, rip-roaring, high inflammatory state. And we really have to be more aggressive depending on patient factors on the anticoagulation prophylaxis, and then continuing anticoagulation after patient is discharged. Next slide, please. So this is an interesting article from Jack Heart Failure, where there were 4 patients. The upper panel is all chest x-rays and the lower panel is CT scans of the chest. The key take home is the lungs are not that much involved, but if you look at the hearts, they're very dilated. So we assume it's the lungs, but it could be kind of independent of the lungs. Next slide, please. So this is an interesting slide. This is an MRI of a COVID patient. So there's if people go on Twitter, Dr. Chetan Chennai is a cardiac MRI expert based out of Minnesota, and he reviewed about 9 papers, 10 papers on COVID using cardiac MRI. And the interesting part is that there's a variety of manifestations. In this patient, the troponin was only 745 nanograms per ml, and the ejection fraction was 15%, but improved to more than 60%. Next slide, please. The reason I'm showing you this slide is actually the right panel where the troponin level was 9,000 nanograms per liter. And guess what? The ejection fraction was normal. So once again, the plethora of manifestations, even just in cardiology, forget about the other organs. Next slide, please. So this is an autopsy series out of New Orleans in an African-American patient. And you can see in this, the heart on the right side is extreme right ventricular dilatation. So much so it's kind of flattening the interventricular septum. It came out in the Lancet. And it just tells you that, in my opinion, this probably is due to severe lung involvement, maybe thromboembolism in the lungs, ARDS causing acute carpopulmonale. And this is the reason probably this patient passed. And I want to sort of emphasize here that the BAME faculty in the UK, that is Blacks, African Americans, other minorities, were very severely affected by COVID. So much so the Royal College of Physicians recommended that people of South Asian origin and other minorities, African Americans, should really think twice before serving in the front line for COVID, particularly if you're obese, you're insulin resistant, you're diabetic or hypertensive, you have vascular disease, you may prefer to do telemanagement. Next patient, the next slide, please. So this is an interesting autopsy series. When they looked at the number of deceased patients of 21, 15 out of 21 had myocardial hypertrophy, 6 out of 21 had senile amyloidosis, and only 3 out of 21 had cell necrosis or cell death, and only 1 out of 21 had acute myocardial infarction. So again, there's a lot of pre-existing conditions clouding the autopsy series too. And the next slide, please. This is just a slide showing myocarditis. Next slide, please. So I want to bring it back to where the virus enters the cells through the lungs by binding to ACE2 receptors on the cell surface. And then the infection can also promote blood clots, heart attacks, cardiac inflammation, and it can affect a variety of organs. And the next slide, please. So I want to finish off by saying, I think what from here forwards, I think just because the pandemic is over, just because the lockdown is over doesn't mean the pandemic is over. And really we have to keep doing what we've been doing, social distancing, hygiene, and being safe, really. It's so easy to get the guard down. The lockdown has been lifted here in Ohio, and we are already sort of relaxing. And it's really important to sanitize, wash with soap, because the vital covering is lipids, and soap takes care of it. So even if you don't have sanitizer, so with that, I'll stop. Thank you.
Thank you, Dr. Baliga. You have been actually giving us so much of knowledge over the past couple of months through all the WhatsApp groups. But there's a question for you specifically right now. And it's, what would you recommend as an anticoagulant for COVID-19 patients? Is it factor 10, heparin? There was also questions about using aspirin and colchicine together.
Yeah, and so we really don't know the data. So there's no data. This is, we're learning as we go along. The only thing constant is change, but extrapolating from other venous thromboembolism situations, I think in the inpatient, it would still be regular heparins and maybe low molecular weight heparins. But you can't keep taking twice a day injections for months and months. And what we do with venous thromboembolism in cancer patients is we use DOACs. And so I would recommend a DOAC, whichever is cheaper, whichever is affordable. I would so the Hematology Society recommends 6 months of therapy if you have a PE or venous thromboembolism. And so I think this is hyperinflammation going on, and just because you're discharged from hospital doesn't mean, or your oxygen saturation returned to normal doesn't mean your inflammation subsided. It's a bit like when we get a big wound on our skin, sometimes it takes weeks for that to heal. And so, especially if you're diabetic, you're hypertensive, you have gray hair like me, you want to give yourself an extended course of DOACs. Not sure about aspirin and Plavix because they're antiplatelet agents, and traditionally we have used anticoagulants. So that's my short answer for what we would use. Yeah, I would recommend, it's all empiric. So the Call Corona studies on colchicine is being conducted by UCSF, NYU, and in Quebec, I think. So there's a multi-center trial going with colchicine in low and middle income countries. We use it in familial Mediterranean fevers. We use it in acute gout, or even, and so it works with inflammation. This is a very, there's myocarditis, so the muscles are inflamed, the endothelium is inflamed. And so I think it's reasonable to use colchicine. It's low cost, it's affordable, and you take it twice a day, you won't get diarrhea. So I would recommend colchicine.